So hi everyone, welcome to this week's talk on Syncope, very kindly being provided by one of our cardiac physician associates, Mish. Before we do get started with today's session, I am aware that today we may have some Edinburgh students joining us. So formerly it's only been located to Manchester, this teaching, but now we're trying to expand. So anybody who has joined us today from Edinburgh, welcome. And if you are watching this back and you're from Edinburgh, again, welcome to this talk. Just a bit about ourselves. So we're CST, Cardiology Student Teaching. We offer sort of 2 weekly or fortnightly online talks about cardiology, ranging from lots of different topics, delivered by, again, lots of different grade specialties, doctors, Mish today PAs, and medical students too. We do have a website that I can get in the link at the end of this video for anybody who wants to access it. And it's quite useful because all of our previous videos are on there, and any videos that you're not able to get to will be recorded and uploaded to there too. We have had previous issues in the past with it, but now it's up and running and there should be no issues going forward. So yeah, without further ado, I will hand over to Mish for today's session, and hope you enjoy.
Thanks, Stephen. Hi, yeah, everyone. My name's Mish. I'm one of the cardiology physician associates at Congenital. I have a slight special interest in echo, so echo and imaging and heart failure. So that's where the things that I enjoy, I think the more exciting part of cardiology. I'm happy to be corrected by anyone at any point. But there's going to be a short talk today, as interactive as possible. Hopefully it will be good learning. It's going to be based on syncope. I'm going to start off the presentation. I'm not pressing that. Can everyone see when I click these things?
Yep.
Maybe it's best if I do. Let's try. Oh, there we go. So we're going to start off with the case. Mr. Smith is an 82-year-old, and he's come in with syncope. His wife's found him on the bathroom floor. He recalls needing to go to the bathroom to pass water. He gets there, and he tells you it's his 3rd episode of syncope this month. He's never had syncope prior to this. No dizziness either. What you know from him is an injury to the right elbow and right forehead. He has a past medical history of hypertension, osteoarthritis, hypercholesterolemia, sorry about the typo there, and angina. Okay, just a bit more about the patient. So he's a retired accountant living with his wife in a bungalow. He self-cares, he drives. He's an ex-smoker of 30 years, and he drinks a glass of wine with his meals and a whiskey in the evening. His past medical, his drug history, he's got no allergies. He's on a atorvastatin, amlodipine, Ramapil, doxycycline. He has a GTN spray. Okay, now my first question, and the question that I always ask everyone when they present, especially if you're a medical student, is any further questions? Are you going to ask anything else in the presenting history? Feel free to jump in. Feel free to ask any questions, and I can answer to the best ability.
Could you go back to the first slide as well, please?
Yeah, absolutely. Sorry, I should have done that first.
I think the first thing you'd want to ask is if he remembers the event and if it was witnessed.
Okay, so it was an unwitnessed event. He does not recall, and that's when he was found by his wife on the floor. His wife had heard the bang, and that's why she'd gone in. So it wasn't a long lie.
And Lucy's mentioned if he had any other symptoms. I don't know, Lucy, if you think of anything specifically, any symptoms specifically. So shortness of breath.
Yeah, he doesn't recall any shortness of breath prior to the incident, and there was no palpitations. Thank you. Thanks everyone for being interactive. Any other questions you might have?
I think sometimes in these scenarios as well, it's quite useful to asked what were you doing 30 seconds prior to the fall, so like a before, during and after. You've mentioned he's needed the bathroom there, but he just sort of ran up a flight of stairs, things like that.
Amazing. Yeah, thanks, Stephen. You're totally right. Things that we should ask. What were they doing prior? And it's not just important for that moment at the time, but actually for probably the first 30 seconds to a minute what they were doing before. So he was just coming out of his bedroom, walking to the bathroom. He lives in a bungalow, so there's no stairs. So he's walked to the bathroom, tried to pass water, and that's it. If there's no, I've got previous maps, if there was someone. Okay. Thanks, Karishma. Yes, so he's had 3 other episodes. Sorry, this is the 3rd episode. So he's had 2 before, both one when he stood up and one when he's doing the gardening. When you say ideas and concerns, is that from the patient?
Yeah, so they typically ask for, so ICE is the mnemonic they use for any ideas, concerns, and expectations the patient may have around their care.
Yeah, perfect. Actually, ICE is really important. I think as clinicians, this is something that we don't ask enough. So you're right. So he's quite worried because actually this time he's had an injury. Prior to this, he had no injuries. And this one has been witnessed by his wife, and the other 2 haven't. Does anyone have any other questions? If not, we're going to move on. Oh, sorry, tongue biting. His wife didn't witness any of that. So no jerking of movements, no tongue bite. Just going to move on for now. If there's any questions, please put it on the chat. I've got the chat up as well, so I'll be able to. Actually, can everyone see the chat when I'm screen sharing?
No.
That's great. Just because I've got the chat up on the screen, I'm just worried that it's in the way of the writing.
No, don't worry.
Perfect. So you are in wherever you are, Rhesus, and these are the observations. Anything you note?
They're relatively unremarkable, but he's got some relatively high blood pressure.
Yeah, pretty unremarkable. You're right. Probably a bit on the blood pressure. If we go back to the meds before, he's on amlodipine, ramipril, doxycycline. So he's known to have high blood pressure.
And his heart rate's kind of borderline bradycardic.
Yeah, heart rate's borderline. Thank you. Absolutely. I'm going to go on to what I would do to examine. I know that I've not done the full cardiovascular. I'm hoping that someone's gone through it, or you'll know your cardiovascular exam. So I've only put the important things on the next slide. But you've seen from the end of the bed, there's no cyanosis, no shortness of breath, no pallor or edemas. But you see the injury to the right elbow and right forehead. So you start examining him. He's got no hand signs associated with infected endocarditis, no clubbing. He's got a good bilateral pulse, but no radial to radial delay. JVP's down. You hear a systolic murmur. His chest is clear. There's no sacral edema, and there's mild pitting edema to his ankles. So you know about that. You know about his obs. The thing is, what tests would you do next?
I think in any patient that's come to hospital, as he said, wherever we are, it's useful to do some bedside investigations first. Any cardiac patient, or you're concerned with a cardiac patient, you'd want to do an ECG.
Yeah.
With that as well, you could do some blood tests. And I think maybe we're jumping the gun a little bit further down the line, but we start a systolic murmur, so we're thinking about an echo at some point.
Perfect. Sorry, is that Stephen? I didn't know who
it is. Yeah, it is.
Oh, perfect, Stephen. You're totally right, and I'm glad you've said that, because I've actually started with investigations by the bedside first. I think a few things that I do by the bedside where it's easy access is your ECG and your BM. I'll go through the results in a second. And the next thing I'm going to do is that a bit further away is chest x-ray and bloods. My BMs has come up again, I'm so sorry. This is probably a typo from the last 2 nights of doing this after hours, so apologies guys. So ECG, BM, chest x-ray and bloods. You are right, Stephen. I actually prefer it when people split up their investigations to what you can do immediately there and what you're expected to kind of have results waiting for. So before we go into the ones that you can request, which is later will be an echo, which we can go through as well, is I have an ECG here. Would anyone like to run through this ECG?
Or if any of the students notice anything on here, feel free to put it in the chat as well. Yeah, sorry, don't feel like you have to speak if you don't want to. It can be really simple, guys, and you don't have to, look at it and say anything. You can even just comment on the rate, the rhythm, don't feel pressured that if you start, you have to finish the whole ECG. Or maybe offer a clue for anyone who is thinking. Oh, someone's might have sent me a direct message. Oh. Maybe not. Okay, someone's gone straight for the moneymaker. Okay, so someone's put heart block on there. Okay, we can go through heart block in a second. I am one of those people, and I'm working on cardiology, and I know that if someone asks me to look at an ECG, I freeze, and the first thing I say is, actually, I'm going to start from the beginning. I'm going to look at the rate and the rhythm. And that's actually sometimes what it depends who you're working with. But I know with Insure, because we're a tertiary centre, the EP consultants would be like, let's start with the rate and the rhythm. Can you, Karishma, can you tell me what kind of heart block you see? Oh, first, perfect, thank you. What else do you know about anything else? Or anyone else? Like, there's no pressure on you. Oh, thank you for joining, even though you're in the library. Studios.
There's normal axis.
Normal axis. Perfect, thank you. And I'm so sorry, I don't know who spoke there, but can I just ask, when you look at axis, what leads are you looking at?
I was looking at leads 1 and 2.
Okay, thank you. To be honest, a lot of people will look at either 1 and 2 or 1 and 3, and if it's in the same direction, everyone says it's normal. If it's pointing away, it's leaving. If it's pointing together, it's reaching. So you're right, it's normal. I don't know if anyone's actually gone through the axis with you guys, or Stephen, if anyone's gone through the axis of ECG teaching.
I think we have had an ECG session by Dr. Landy previously, so I think she may have touched on the axis there. But
great, because I don't think tonight is
No.
it's
One thing
definitely not been my forte. That's me being honest.
One thing I'd say,
axis.
one thing I'd say, especially for those who are preparing for finals, is I wouldn't worry too much about axis.
Yeah.
And you won't be asked about axis in your finals. And if you are, it'd be very, very harsh. The only situation it may come up in is with a PE, where you might need to see right axis deviation.
Yeah, thank you, Graham, because I wasn't actually going to go into any details, and I was just wondering if anyone had gone through with you guys. I kind of cheat. I do the lead 1 and AVF, and then look at lead, depending if they're both positive, then it's normal. And then you look at lead 2. That's also an easy way of doing it as well. So I won't go into detail because I don't really think you need it at this point. Perfect. So Ray, what do you guys think about the rhythm?
It's quite hard to see without a rhythm strip, but it does look regular.
And another question I think is really important when we think about heart block is actually, what do you think about the QRS intervals? Are they wide, narrow?
I mean, they look normal, like narrow, like less than 3 squares.
Yeah, perfect. Thank you. I tried to choose an ECG where you could see the squares behind, just so that you could get your eyes familiar with. Yeah, it's a narrow QRS, so QRS is normal. Right. And you're right, that's first degree heart block. Okay, I'm going to go through the bloods. Oh dear. I'm going to go through the bloods now. Okay, so you've got your BM. Your BM's come back as 5.6, which is normal. And then there you use these. It's U and D. Sorry, I always get picked up by the consultant. It's only one urea. So it's U and E, so apologies. So you can read through them, and FBC as well. Perfect. And we're just going to leave them on the screen just so they're there. And then I'm going to let you see a chest x-ray. So just, I can go back to the bloods in a second if you'd like, but I'm just going to go to the chest x-ray. Can you see that clearly?
Yeah.
Perfect. Does anyone want to go through the chest x-ray? I'm starting to ask a bit much, aren't I?
No, not at all.
There's only a few of us in.
Sorry.
There's only a few of us in. I'm happy to go for it though.
Oh, thank you. Thanks.
So if I was presenting an OSCE, I'd say I'm looking at a plain film radiograph of a chest. I'd look at if we had a patient identifiers, name and so on, to make sure it's the right patient. Then look at the orientation and if it's AP or PA. I often forget which one is AP and PA, to be honest. But I can see that the scapulae are not covering the chest, so it's a good quality radiograph, and you can see the full chest. There's no gross abnormalities, but then looking a bit more detailed, I'd look at the airway first. The airway looks central, not deviated, and you can see the carina, and that's deviated. That's not deviated. I then look at B, so breathing, to look at the lung fields. They don't seem to, there's no hyper expansion. There's good air entry throughout. I can't see any pneumothorax. Then go in at the claustrophrenic angles are present, and there's no effusions down there. Then I'd go to C, so cardiac, so looking at the heart and the great vessels. It's around about 50% of the width of the left side of the chest, so there's no cardiomegaly. If there is, it's very mild. You can see the knuckle of the aorta, and it's not a widened mediastinum, so that looks normal as well. Then looking at the hilum, doesn't seem like there's any kind of lymphadenopathy or anything there. Doesn't look like there's any pulmonary congestion. So looking if there's, you can see venous congestion, which is quite hard to describe and easy just to point at. But it doesn't look like it's overloaded from that point of view. That's C done. D, I think it's diaphragm. So I'm doing the A to E if anyone's come across that. So diaphragm is not flattened. It looks normal. There's no air under the diaphragm. You can see the gas bubble of the stomach. E would be everything else. So I'm looking for kind of bony and soft tissue. I don't see any fractures. There's no surgical emphysema. So overall, I'd say it looks like a normal chest X-ray.
Thank you, Stephen. Thank you so much. You've gone through everything so systematically, and this is something that I'm so passionate for as well. And from an early stage, like your ECGs start with rate rhythm, your chest X-rays. When I look at chest X-rays now, I always do an A to E assessment to make sure I've not missed anything out. So thank you for that. Thanks, Stephen. I'm going to ask you guys now if you guys have any just differential diagnosis. Have a little think. I'm just going to admit feel free to just chat, or feel free to, just post in the group. Yes, postural hypertension. Perfect. Thank you so much, Graham. You are totally right. I think in anyone elderly, that's over 65, and feeling dizzy when they go to the toilet is actually quite common to postural hypertension. And a lot of the time, for example, if someone's in the bedroom, like I said, or someone's in the living room, they sat on the sofa and they get up quickly, postural hypertension might not happen straight away. It might be after a few seconds when they get to a specific destination. Thank you so much. Lucy, vasal syncope. Yeah, you sat down, you can be heart flustered. Absolutely, you can go. First degree heart block. Yes, first degree heart block. First degree heart block. Yeah. True syncope and abnormal heart sounds. You need to think about valvular disease. Just trying to. Yeah, sorry, I'm just having like a good. Everyone's just posting things. So I'm trying to read first degree heart block, which is what we saw in the ECG. Question about first degree heart block. Does first degree heart block cause syncope?
I think characteristically it normally doesn't, does it? It's once you get into the later realms of your second degree heart blocks is when you start to worry about syncope. Yeah,
a lot of people do end up having first degree heart blocks, but it's actually normally it doesn't cause syncope that quickly. Actually, it's normally when it develops into other things, when the PR interval gets longer and longer, and then you run into things like bundle branch blocks. But those are normally initiated by other things as well. History of syncope and abnormal heart sounds. You need to think about valvular disease. Yeah, absolutely. Additional syncope. Yeah, actually, a lot of people do, especially older gentlemen with any sort of BPH or anything, and they're pushing to pass water. Sometimes you do get that time of syncope. So absolutely, things that I haven't thought about. So thank you so much. Right, the first thing I'm going to go through, we talked really quickly about first degree heart block. I'm just going to talk really quickly about heart block. We looked at it before and we saw a first degree heart block. Did we see anything else? I'm just going to go back to the ECG really quickly. I'm just going to ask you if you guys saw anything else. I know the tracing isn't good, and apologies, I don't have a rhythm strip. What's the QTC? Now you're asking, Graham. Okay, I'm actually gonna count 1 second. So can you see the mouse when I'm sharing?
Yeah.
Perfect. Okay. So how would you calculate the QTC?
I would use MedCalc to calculate the corrected.
No, do you know what, Graham? Is that Graham?
Yeah.
I appreciate that honesty, because when I first started, that's exactly what I did. And I used to, and now when you're on the ward round, the consultant's like, Mish, what's the QTC? And I can't really get my calculator out after like being here for 3 years. So what I normally do is, it is different, you are right, because actually if they're going more bradycardic, they are more likely to look like they have a prolonged QT. But the idea is, if you look at both, the quickest way to look at it, and I'm not going to do it, this is how I look at it when I'm quickly at work, is if you look at the R to RR interval, if the if the T wave crosses the line after halfway, then it's normally a prolonged QTC. So let's just say this one to this one. If the T wave cut the line past this point, then I know it's prolonged QT because it's more than half of the RR interval. But actually in this case, they don't have a prolonged QT. Anything else? You can say there's nothing else as well. No worries. I'm just going to go to the slides. I'm conscious of time. Also, I don't want to put anyone on the spot. These sessions aren't meant to be like catching anyone out or anything. So the reason I put heart block in here as well is because actually it's something that's considered by a lot of people, and A&E refer a lot to cardiology in regards to heart block. First degree heart block is basically a prolonged PR interval. So what's the PR interval range?
120 to 200 milliseconds, or 3 to 5 small squares for anyone who likes these squares.
Yeah, thank you so much. So yeah, prolonged PR interval, anything over 200. So it's actually quite commonly a lot of people have prolonged PR, and actually it's mostly an incidental finding when we ask for anyone to do ECGs. I'm going to go on to the next slide because I'm going to talk about MOBIS 1 and MOBIS 2 really quickly, which is not on the ECG. The ECG, you're right, is just showing a first degree heart block. So this is basically MOBIS type 1 is when the PR interval gradually gets longer and longer, and then basically a P wave is completely blocked. So you it gets longer and longer and longer. And then basically it might drop. And then MOBIS type 2 is when the PR intervals are consistent, but actually some P waves don't follow. Basically, a QRS doesn't follow a P wave. Okay. Does anyone need me to repeat that? To be honest, reading it is probably better than listening to me. I've taken this from Osmosis. Osmosis does a really good ECG teaching. And then I'll do basically the next thing that really worries us in cardiology mostly is complete heart block. Complete heart block is, in all honesty, you can see a mile off in the sense of their heart rate by the time they come to you or they present in hospital is normally very bradycardic. So all you need to do is look at it from afar, and if the ECG strip looks like they're running around about 40, they've got a dissociation of P waves and QRS, that's complete heart block. So in the ECG, it just showed first degree heart block. So that was a bit of a red herring, guys. I'm sorry. I said I'm not here to trick you, but also I just want you guys to be able to differentiate, your different types of heart blocks. I'm going to go now onto the next bit, which is I told you I heard a systolic murmur. Okay. So which are the systolic murmurs?
Aortic stenosis and mitral regurg.
Yeah, aortic stenosis, mitral regurg. Yeah.
So I think they're the most common ones that you're likely to come across. You can also get right-sided systolic heart sounds as well. A little bit more uncommon.
Yeah, absolutely. If you get a lot of heart failure, sometimes you can basically hear TR as well, but if you don't do cardiology, you probably won't need to hear that. You would probably be able to see that if they had severe TR, you would be able to see their JVP up, you'd see their legs swollen. I've just gone through the murmurs there, and then I've gone through which are the systolic murmurs and where they would be based. So you can just have a quick gander there. So, oh dear, cheated. Right, so the patient that we investigated had a systolic murmur. It was in line with the pulse. So a systolic murmur is always in line with the pulse. And normally, if you want to feel their pulse, I'd normally go for a central pulse. So either their brachial is probably better than the radial, but anywhere. The murmur is after the first heart sound and finishes before the second heart sound. Loudest is in the second intercostal space, right sternal edge, radial intercarotids. So which murmur is that?
The aortic stenosis.
Perfect. Thank you. Thank you. So great. So I'm going to go through what aortic stenosis is. I'm going to be really honest, I really tried to get some echo images, but unfortunately, I wasn't sure we've just changed our echo system this week, and I've not been able to get the echo images, so apologies for that. Aortic stenosis. Thank you. Don't worry, Krishma, go. Honestly, don't worry. So aortic stenosis is a narrowing of the aortic valve. The aortic valve is a separation between the left ventricle and the aorta. So the aorta is pumping blood out of the heart into the rest of the body. I put a little picture there just so people know where it is, but I'm sure everyone knows where the aorta is. So sorry if that's a bit patronizing. I think it was just one that could show us what it looked like in color for the narrowing of the valve. So what are the causes of aortic stenosis?
I think the most common is age, degeneration, and calcification.
Yes, yes, absolutely.
I think with this chap, if we remember back to his history, it's important to remember he has hypertensive heart disease. So he's got increased afterload.
Yeah. I've gone through in the next slide. So congenital heart defect is one, and also another common one. And actually, the more of a reason for younger people to have any sort of intervention. So I'll put that one first, not because it's anything more important. I was trying to just congenital heart disease and calcification, and then normally infected conditions. So rheumatic fever normally causes things like mitral stenosis, but can cause aortic stenosis as well. And then mostly things like endocarditis is involved as well there. I'm going to go through what congenital heart defect do you know that can cause aortic stenosis?
The classic pass med question.
Well, it'd be good. Yeah, it'd be good if it came up. Easy point.
Is it a bicuspid aortic valve?
Yeah, absolutely. Absolutely. So what we can see here, I've put a picture of bicuspid aortic valve. In the bicuspid aortic valve, this is your normal aortic valve. It looks like Ben's Mercedes sign. And your bicuspid aortic valve normally actually looks like this. Now, a lot of people believe that if you have a bicuspid valve, it cuts it in the middle here. But I've just put a classification of the bicuspid aortic valve there. And you can see in this one, the true bicuspid aortic valve cuts it in the middle as we think it's cut in half. But actually, that is really, really rare. Normally what happens is this type 1. This is your aortic valve. This is your right coronary cusp, your left coronary cusp, and your it's your non-coronary cusp there. And what happens is actually as you develop, the right and left is fused together. And so that's why you get a round bent shape. And actually that is more of a reason that you get calcification and buildup or restriction, because actually that opening's always been quite small from outset. So actually that actually takes up most high percentage of bicuspid aortic valves. So actually true bicuspid is actually really rare for us to see. And right, we're going to go back to aortic stenosis, and we're going to have a little look at what we think. Aortic stenosis, the classic triad, and this is how I always remember it, is people with aortic stenosis are sad. So you get your syncope, your angina, and your dyspnea. I think there's a few important questions to ask whenever we see anyone with any valvular disease, whether it's aortic stenosis or not. Questions that we should ask is things about exercise tolerance. You know, I asked before in the presenting plates, any more questions you could ask? And these are just a few things that I would, always recommend to differentiate if whether they come in with syncope or whether they come in with shortness of breath, exercise tolerance. So, and the reason they stop, if they're telling you they can't get from the house to the car, but they can't do that is because they've got knee replacements, hip pain, then that's a different situation. But exercise tolerance, if it's related to shortness of breath, if the reason they stop is because they feel dizzy, or if they get chest pain, then it's actually more indicative of cardiac problems, orthopnea, PND, and the number of pillows patients sleep on. Always ask those questions and see if there's any other signs. Chest discomfort with them. I think a lot of people use the word pain, but pain is different for you and me. So I tend to ask patients about discomfort. Is it tight? Is it sharp? Is it like a band around your chest? And how does that resolve? Is it with a GTN spray? Or is that actually with rest if they have shortness of breath? Another thing I always ask is actually, when did they notice their decline? A lot of people that have valvular follow-up, they know they have, for example, moderate aortic stenosis, might say to you for the last 15 years, they've been walking the same amount of distance. And unfortunately, they'll say to you, but I've had one chest infection and this is what happens. So aortic stenosis or severe aortic stenosis, I should have actually got an echo up, but is when you have a tight narrowed aortic valve and when the area becomes less than 1 centimetre squared. There are options. So if it's less than 1 centimetre squared, you are getting symptoms, which is this syncope, angina and dyspnea, which I was talking about. You'll have to be treated. There are important ways to consider them as a person. So there's medical management, and in all honesty with that, it's more of blood pressure control, more of considering what medications they can have so they don't have as much syncopal episodes. The gentleman that we were talking about today had 1st-degree heart block, so I would be stopping things like bisoprolol and ensuring there's no syncopal episodes from that point of view. He's not on any bisoprolol. And then we need to consider actually interventions for severe aortic stenosis. There are 2 types of interventional approaches. And one is the classic aortic valve repair and replacement, and that is done in 2 ways. Either you basically do full open heart surgery, which is the central stenotomy, or you can have, which recently has come into place the last couple of years, is minimal invasive. It's basically still a stenotomy, but it's about 5 to 7 centimeters instead of, the 10 to 15 that you get. And people sometimes opt for those, especially if they've previously had a replacement before and it's second replacement, or if they've, young people. Now, you can also have a separate intervention, which is a percutaneous intervention. It's called a Trans-Aortic valvular implantation, which is called a TAVI. If you are in the UK, it's called a TAVI. If you're in other countries, sometimes they are called TAVR. So instead of an I, it's an R. And what happens is you can put this valve in through someone that doesn't need to be under general anaesthetic, but local anaesthetic. And what you can do is you can just pass a catheter through their groin and intervene from that point of view. And what you do is you go femoral artery, and you bring the catheter around the aorta, and then you have another access for contrast. You put contrast through the valve to see how stenosed it is, and then you open it with a balloon, and then the TAVI can be put in, which is a new cage, and open it up. Now, a lot of people ask, when do we decide which one of those 3 to do, especially with old people? And I put a bit of things to consider on this page. And I think the important thing to think about is who the person is, and their age and their comorbidities come into play. And that's not just, it's not if they're older, that they wouldn't be for surgery and they go straight for a percutaneous approach. It's more of if they're if they're fit for their age, and it's the way that they look and the way they kind of exercise, that kind of age. I'm not saying you know, that if they're 80, then they wouldn't be surgery for TAVI, because we have sent people in their 50s for TAVIs as well. Comorbidities, and these include a lot of different things. If someone has lung disease, COPD, if they have a lot of chest problems, you wouldn't consider putting them under GA. You know, that wouldn't do them any good. They would probably go under GA, and they'd probably struggle to extubate them. And so, you know, you might have fixed their heart disease. You know, the surgeons will be glad that they put the valve in, but unfortunately the patient wouldn't survive to know the benefits of that. Other things that have problems, some people have chronic back issues, and actually they can't lie flat under local for things like TAVIs. So those things. Body habitus sometimes is also a difficult one, because a lot of people, for surgery, you know, we can give them a chance to lose weight for surgery, but unfortunately when you have a severe aortic stenosis, you wouldn't probably have the chance or the time to lose weight if you already think it's a problem. If you have aortic stenosis and you present or you have any sort of decompensation, then actually you know that your window for further decompensation is there, and actually to intervene you don't have much time. I put complications there, and I put complications because a lot of patients come in with complications with other things as well. They might choose actually at that point not to have their valve done. We've recently had a patient that's come in and she declined having surgery 2 years ago because of family bereavement, and now she's come in. Unfortunately, she's not fit for surgery, but it doesn't mean she'll be fit for a TAVI because of a delay in previous heart disease. And heart intervention is really important, and I think there's a few reasons for that. If they have had early surgery, then actually, you know, having another open heart surgery wouldn't be appropriate. If they've previously had any infarcts and it's caused any sort of muscle damage, as we classify as left ventricle systolic dysfunction, then actually, you know, to put someone through that, they probably would struggle, their heart would struggle post-recovery, and they go into a lot of problems like pulmonary edema, heart failure. Now, heart failure works both ways, unfortunately. If they've had previous heart failure, then surgeons aren't keen to operate because actually they're more likely to run into complications. But actually for things like TAVIs, where you have to lie flat for, if you have any sort of heart failure and you go into pulmonary edema on the table while they're putting the TAVI in, that is also really high mortality. I wanted to ask a quick question. Does anyone know how long and what the prognosis is of anyone with aortic stenosis if they present into hospital? I'm just going to chat. Their mortality in the next year, if they've presented with severe aortic stenosis, is 50%. So if I think one thing that I would say as well is if patients don't know that, then actually when you send them home not for surgery and, you know, not for intervention, then actually these things need to be discussed with them, and especially in their elderly age, it should be discussed with family as well. I'm going to go back to the case. I'm just going to go back to, oh dear, sorry. I'm going to go back to the start where I've discussed this gentleman. I've mentioned that he is a 85-year-old gentleman. He has syncope, no other history, just hypertension, cholesterol, angina. No other issues to note here. I just want you to have a little think about what intervention you think he would be suitable for.
Doesn't have too much of a past medical history, and it sounds like he was relatively mobile. That you said he was doing gardening and so on, so had a decent functional baseline.
Yeah.
So I think he, you know, I think could possibly have a aortic valve replacement, but then TAVI if not.
Perfect, thank you. Yeah, I think that's one thing that I wanted to leave open is actually people at this age should be really discussed about what the best thing for them is. You know, actually another thing to note is that he was fit and well before, so actually his recovery, he lives in a he lives in a I don't know where he, did I mention that he lives? Yeah, he lives in a bungalow, so it's not like, you know, it would take him long to get back to baseline. There are definitely a few things that I would say, reasons that would cause him, the surgeons, to kind of hold their hands up and say, I'm not too keen, is the ex-smoking history. And actually how much he drinks will, the surgeons will be worried about things like that as well. But actually, yeah, these people, you shouldn't write old people off. I think that's one thing that I'm really passionate about. So yeah, I'm just going to end it there. Does anyone have any questions?
That was fantastic. Thank you so much, Mish.
No, none from me. That was really good.
Thanks, guys. We can stop recording and we can ask more questions if you'd like.
Yeah, fantastic.